Here I'm going to talk about different joint diseases including osteoarthritis, rheumatoid arthritis, as well as septic arthritis. So starting with osteoarthritis, this is a condition where wear and tear of the articular cartilage will cause joint disease. And risk factors to osteoarthritis includes age, where increased use of the joints will cause cartilage damage. Obesity is another risk factor since it places more weight on the joints and cause crushing of the joints and the cartilage. And then finally, trauma can damage the cartilage and cause joint disease. So the presentations of patients with osteoarthritis is a morning stiffness that lasts less than 30 minutes and worsens with activity. So the fact that the joints has been destroyed there and there is no cartilage, now the bones are rubbing on top of each other. And thus with increased activity, the pain worsens. It's important for you to know that rheumatoid arthritis is also presenting with morning stiffness, but then with rheumatoid arthritis, the morning stiffness lasts more than 30 minutes and then it improves with activity. So with osteoarthritis, morning stiffness is less than 30 minutes and worsens with activity. And so that's one feature that can help you to distinguish osteoarthritis from rheumatoid arthritis. Now, in terms of the number of white blood cells that you find on joint aspiration, the number of white blood cells is less than 2,000 per millimeter cube of the joint aspirate. Now, there are other clinical features associated with osteoarthritis, and these include the bony overgrowths, where these are referred to as Bouchard and Heberden's nodes. So Heberden nodes are in the distal interpharyngeal joints, while the Bouchard's nodes are in the proximal interpharyngeal joints. And so here I would like to review the anatomy of the hand bones with you. So here we have the distal interpharyngeal joints. So these are referred to as DIP. And then after that, we have the proximal interpharyngeal joints, or PIP. And then finally, we have the metacarpopharyngeal joints, which are referred to as MCP. So generally with osteoarthritis, it's DIP and PIP that are being affected, but not the MCP. So here, the presence of the bony overgrowth in DIP was referred to as Heberden's nodes, while their presence in the PIP was referred to as Bouchard's node. And if you have difficulty remembering which one was which, here I have a memory aid for you. A, B, C, D, E, F, G, H, I, and so on. So let's say that the alphabetic letters are a rope. So the first part of it would be proximal part of a rope, and then the end of it would be the distal part of the rope. So now you can see that the Bouchard nodes are in the proximal part, so these are in the proximal interpharyngeal joints, while the Heberden's nodes are in the distal part. So Heberden's nodes are in distal interpharyngeal joints. So back to the image I had for you here. So Heberden's, you can see that they're in the distal interpharyngeal joints, while Bouchard are in the proximal interpharyngeal joints. And then here I have an x-ray that shows you that there is a narrow joint space, so you can see that the bones are now rubbing on top of each other, and so that's why that the bone pain worsens with activity. And then another feature of osteoarthritis is the presence of bony spurs, which are referred to as osteophytes. And so here is an example of a bony spur in osteoarthritis. Now, as for the treatment of patients with osteoarthritis, since obesity is one of the risk factors, therefore weight loss is recommended as one of the treatments for osteoarthritis so that there would be decreased weight on the joints. In addition, it's recommended to exercise in order to strengthen the muscles that are supporting joints. So by strengthening the muscles that are supporting joints, now the muscles will pull the bones away, and so therefore the bones will not rub on top of each other as bad as they would before the muscles were strengthened. So exercise in order to improve the muscles that are supporting the joints would be another treatment option for osteoarthritis. And then in terms of the pharmacotherapy, the first medication that you should consider is acetaminophen. And then after that, the other medications that you could consider include topical NSAIDs, like for instance, diclofenac. And then you can also consider topical capsaicin. And then for patients that have moderate to severe form of osteoarthritis, you could consider intra-articular injection of the glucocorticoids. Now I would like to let you know that there are some physicians who may still be practicing with use of the glucosamine as well as chondroitin for the treatment of osteoarthritis, but there has actually been controversial results regarding the effectiveness of these treatments, so therefore it's not recommended to use any of these medications. So just to summarize the treatment options, so you should consider weight loss in order to decrease the weight that is being placed on the joints. You should consider exercise to strengthen the muscles that are supporting the joints. And then in terms of the pharmacotherapy, the first medication that you should start is acetaminophen. You can also consider topical NSAIDs as well as capsaicin. And then for severe as well as the moderate forms of the osteoarthritis, you could consider the intra-articular glucocorticoid injections. The next condition is rheumatoid arthritis, which is a symmetric form of arthritis that can affect multiple joints. And so this type of arthritis is an inflammatory erosion of the synovial joints that is caused by type 3 hypersensitivity reaction. So if you recall, type 3 hypersensitivity reaction is a form of hypersensitivity that is caused by antibody to antigen complexes that are formed. And so these antibody-antigen complexes cause inflammatory reaction. So here, the antigen that we are having is the IgG antibody itself. So this one is the antigen. And then the IgM is attacking the Fc portion of the IgG. So here we have the antibody, which is IgM, attacking the IgG as an antigen. And so therefore, this antibody-antigen immune complexes is what induces the inflammatory reaction. And this complex is referred to as rheumatoid factor. And so in fact, the lab findings that you see in patients with rheumatoid arthritis includes the presence of the rheumatoid factor as well as the anti-cyclic citrullinated peptide. In addition, there would be elevated erythrocyte sedimentation rate as well as elevated C-reactive protein. And then in terms of the genetic association, presence of the human leukocyte antigen DR4 gene loci predisposes patients to the development of the rheumatoid arthritis. Now, in terms of the presentations of patients with rheumatoid arthritis, they present with a morning stiffness that lasts more than 30 minutes, and this type of stiffness actually improves with activity. Now, on the joint aspiration, the number of white blood cells that you see are 5,000 to 50,000 per millimeter cube. Now, in addition to the morning stiffness, there are other presentations associated with the rheumatoid arthritis, and these include pain and swelling, and as I just mentioned earlier, morning stiffness that lasts more than 30 minutes. In addition, there would be symmetric arthritis. So if the arthritis, for instance, is affecting the left hand, the right hand will also be affected. So it's a symmetric arthritis. Versus osteoarthritis, which could be asymmetric. So if, for instance, the left knee is affected, it doesn't necessarily mean that the right knee is affected. In any case, back to the topic, with the rheumatoid arthritis, there is a symmetric arthritis. And then there are deformities, like for instance, ulnar deviation, where you can see that the fingers are being deviated towards the ulnar portion of the hand. So here, you can see that all the fingers are being deviated towards the ulnar side. So here on the top, we have the radial side, while at the bottom, we have the ulnar side. So the fingers are being deviated towards the ulnar sides. Other findings that you see in patients with rheumatoid arthritis includes the presence of the subcutaneous nodules, which is due to the formation of the fibrinoid necrosis. So here you can see on the elbow, we have the subcutaneous nodule. And then in addition, there would be granulation tissues that are formed inside the joints, and it's usually affecting the MCP and PIP joints, and this granulation tissue is referred to as pannus. Now finally, in addition to ulnar deviation, there are other forms of deformities that are seen with rheumatoid arthritis, and these include swan neck deformities, where you find that the DIP has flexion while the PIP has hyperextension. So flexion of the DIP and hyperextension of PIP shows swan neck deformity. On the other hand, these patients can have boutonniere deformity, where there is a DIP hyperextension, but then PIP flexion. And so this is referred to as boutonniere deformity. Now, as for the treatment of patients with rheumatoid arthritis, you should consider treatment with disease-modifying anti-rheumatic drugs, and the best medication that you should try is the methotrexate. So in fact, trials show that the earlier you start treatment with methotrexate, the better the outcome of the results. So if they provide you presentations of a patient on the exam where they are presenting with pain and swelling that improves with activity, it usually presents with a morning stiffness that lasts more than 30 minutes, and then on the options they say like which of the following should you pick as a treatment option for these patients, you see that there is methotrexate, NSAIDs, acetaminophen, glucocorticoids, hydroxychloroquine, infliximab, and so on. And then if you have to pick among all those medications, methotrexate is the #1 treatment for rheumatoid arthritis. Now, once you start methotrexate, which you should start as soon as possible for the best outcome, you could consider also prescribing NSAIDs and glucocorticoids to help relieve the pain until methotrexate starts to take full effects. Now, there are some people that are resistant to methotrexate, and so in those cases, you should consider combination therapy with methotrexate and another medication, like for instance, hydroxychloroquine, or you could consider sulfasalazine, or you could consider the TNF-alpha inhibitors, like for instance, infliximab. The next and final form of the joint disease is septic arthritis, where there are microorganisms that penetrate the joint. They could penetrate via the blood, so if there is, for instance, sepsis in a patient, now they could spread to the joint and cause septic arthritis. They could spread from a local infection, or they could spread from a traumatic injury. And so on the actual joint aspiration, the number of white blood cells that you see is more than 50,000. So you may recall that with osteoarthritis, it was less than 2,000. With rheumatoid arthritis, it was 5,000 to 50,000, and now with the septic arthritis, it's more than 50,000. And then the infection can be caused by bacteria as well as the fungi or mycobacteria, but it's usually bacteria that is the most common cause of the septic arthritis. So once bacteria enters the joint space, it will cause acute inflammatory reaction inside the synovial membrane, as a consequence of which there would be hyperplasia of the cells that are lining the synovial membrane. And so therefore, these patients present with limited range of motion in addition to pain, swelling, as well as warmth over the joint. Now, in terms of the most common causative organisms, Staphylococcus aureus is the most common cause overall. So this is the most common cause overall. But then in certain age groups, like for instance in young adults where they're sexually active, Neisseria gonorrhea is the most common cause of septic arthritis. And then for the diagnosis, you could consider analysis of the synovial fluid. So you could start with the synovial culture as well as the Gram stain, and then if you analyze the synovial fluid, you can see that it could be purulent, which suggests the presence of the bacteria. And then again, as I mentioned earlier, the average leukocyte count in patients with septic arthritis would be more than 50,000. Now, for the treatment of patients with septic arthritis, you should consider joint drainage. So you can consider starting with daily needle aspiration for about 3 to 5 days. And then if there has been no improvement, then proceed with the surgical drainage. And then depending on whether the Gram stains shows the presence of gram-positive cocci or gram-negative bacilli, then you could consider starting different kind of antibiotics. So if there are gram-positive cocci, since we know that Staphylococcus aureus is the most common causative organism, then you should consider starting the patient on vancomycin. On the other hand, if there are gram-negative bacilli, then you should start treatment with the third-generation cephalosporins, like for instance ceftriaxone or cefotaxime. And that concludes our discussion of different forms of joint diseases.